लैपटॉप के वाला Right. Yes, yeah, I'll give you the mics. I was discussing. I don't think we need that. Because it's going on live. It's going on live. Okay. Good morning, and on behalf of Diabetes in India, I invite all of you for this Retina workshop. And I'm Dr. Sanjay Reddy, and to moderate the session, we have Dr. Fundus Sheikh. She's from Mumbai, and then Ashish Gopal, who's from Macular, who I learned recently. Glad to meet both of you.
Yeah, I welcome you all. I know it's really hard after a Saturday night in Goa to come at 10 to attend a workshop. So,
So me and what we will do is we'll keep it interactive. There are a lot of slides and other things, but what we do here is we have Dr. Kiran who's joining me with to do this workshop. So none of us are ophthalmologists. So first statement on this. Now, I was asked to talk about interpreting fundus photograph in medical retina, but I'll only stick to diabetic retinopathy. The reason is, even as an MD, I couldn't make out too much you're saying in the ophthalmoscope. Let me be frank and honest with you. I don't know how much. Yes, we could make out sometime. This is because of all of them would say, "Oh, I saw this." I said, "What did you see?" It's so. It requires a lot of expertise to watch fundus, to keep observing funduses and learn from them. So now, how many of you examine retina in the clinic regularly? You do it, you use a... You have a force. That's the first mission we used. That is 15 years ago. Now, it's gone now, so good. So what we did is, now the problem with most of the cases, or most of the centers, or wherever you are, nobody is examining the fundus. The bottom line is this, like how we had foot workshops those days. How many of you have a foot clinic?
if you detect diabetic retinopathy on a newly diagnosed type 2 diabetes mellitus patients. Even the UK PDS says that 21% you will get diabetic retinopathy on detection. So, which means in newly diagnosed type 2 diabetes mellitus. So, here is a patient, and these are the hard exudates which are classically seen on the fundus images, as well as, in fact, this patient came with a visual complaint, and then we realized that the patient has got diabetes mellitus. So, apart from diagnosing the diabetic macular edema or various changes in the diabetes, OCT is also used to understand which patient needs anti-VEGF injections, to monitor the anti-VEGF injections, whether the retina is settling down, or to understand whether there is coming back of the normal foveal depression. So here the thickness was around 370. That's the time where the first dose of anti-VEGF was given, and you can see subsequently the patient has been monitored. Apparently the patient got 3 anti-VEGF injections, and finally sometime in 8 months the retina is completely settled. So we use the OCT scan also to monitor, just not screen for diabetic macular edema. This is very important, which I feel as a diabetologist. Please understand, pioglitazone is one of the reasons for diabetic macular edema. We have seen thousands of patients. This is just data of approximately 10 patients, which I'm trying to highlight out here. Pioglitazone can cause diabetic macular edema apart from all other complications you know or understand as far as this particular molecule is concerned. Now here is a patient who I have written triple drug OHAs. There was a time when we used to get combination of glimepiride, metformin and pioglitazone. Of late we get the voglibose, but there was a time when pioglitazone was there. And whenever a physician tries to make it twice in a day or 3 times in a day, BD or TDS, indirectly the glitazone becomes 30 milligrams and 45 milligrams respectively, and that's the time when you risk your patients to develop diabetic macular edema. So you need to understand even the medical history of this particular patient. It's just not the retina, but you've tried to figure out if this patient is on a glitazone. So in here, there was no anti-VEGF given, there was no laser which was given, it's just that the drug has been withdrawn. And you can see subsequently 4 weeks down the line, there is spontaneous and fast resolution of diabetes macular edema, and the visual acuity improved after stopping the glitazone. I always show this particular patient way back in November 2015, And he's a medical tourism patient, and he had come to our hospital finally before traveling to all these 6 other places. And you can see the amount of anti-VEGF which cost anywhere from 40,000 to 63,000. Despite this, there is no improvement in diabetic macular edema. So what came to us was a non-resolving diabetic macular edema who has been injected all these injections for over possibly 6-7 injections. So was this a case of refractory diabetic macular edema was the question. This is the report which we first saw, and you can see there is diabetic macular edema in both the eyes. There is complete loss of foveal depression. And this is the patient who was unable to tell us what medication. We tried to figure out what is the medicine he's taking for the management of diabetes, and he was taking pioglitazone 3 times in a day for 1 year. And the reason he was being put on this drug because he wants to gain weight. So the endocrinologist pushed him to 3 times in a day, thinking that the weight will gain, but the weight did not gain. He gained weight somewhere else in the eye, and that was not responding. Now coming back to the original slide, imagine the cost of the injections and imagine the cost of pioglitazone, just 58 rupees. So we are actually selling our patients to an ophthalmologist, you treat, and we are just not getting anything out of it. So just imagine, just stop the drug of pioglitazone, and this is after 3 months, he's come back to us and there is completely nothing out there. So he does not need injections. It was the drug which was causing the macular edema, and you are just injecting anti-VEGF injections. Now, a patient with established diabetic retinopathy, irrespective of whether it is non-proliferative diabetic retinopathy or proliferative diabetic retinopathy, these patients have a more tendency to develop diabetic macular edema. So if you add pioglitazone in these patients with established diabetic retinopathy, this is what you get. You will get diabetic macular edema. So that's the time you again stop the glitazone. This patient subsequently received 2 doses of anti-VEGF, and he also got a pan-retinal photocoagulation. This is my unpublished data. It is currently under review. Can we use SGLT2 inhibitors in the management of diabetic macular edema? Now, these are just 10 cases of the 20 cases. I could not show each and every one, but I've used empagliflozin, canagliflozin, and dapagliflozin. The first 4 cases are having diabetic macular edema in both the eyes. Subsequently, from the 5th case, you can see till the 10th case, it's just one eye which has been affected. The blue line shows the baseline thickness, the central retinal thickness, whereas the red snake particularly shows after the initiation of the SGLT2 inhibitor, there is decrease in the central retinal thickness. Just to highlight a couple of cases, if you can see case 7, 4 injections have been given before the initiation of the SGLT2 inhibitor. After the initiation of SGLT2 inhibitor, there's only 1 injection which has been given. Similarly, in case 8, 4 of them were given. After the initiation of SGLT2 inhibitor, you can see nothing has been given. So I'm not saying that an SGLT2 inhibitor is a replacement for anti-VEGF, no. But anti-VEGF is still the first line of treatment. If the number of injections are being reduced because of a particular treatment, why not use it? Per se, 30% of the patients who receive an anti-VEGF injection are resistant to their particular treatment, and there is no pharmacotherapy as far as diabetic macular edema is concerned. So why not use an SGLT2 inhibitor, and subsequently see we saw particularly improvement. So let's see. So this is one of the cases, diabetic macular edema in both the eyes. We did use an SGLT2 inhibitor. You can see subsequently on the left hand side, the left eye did get a second injection, but the right eye actually showed dramatic improvement, and there is complete resolution of edema in both the eyes over a period of 5 months. Now, this is very classically seen as cystoid macular edema after post-cataract surgery. Remember, we usually give fitness for cataract surgery. Please look into the glycated hemoglobin at once. At times, even do not allow your patients to go. They operate. I would say the ophthals operate 180, 200. They just operate. But what comes back to you is this particular phenomenon, which is called post-cataract surgery cystoid macular edema. It's very common, and usually it goes back to the ophthal. So that's the colored picture of the patient who has been operated. In this patient, you can see vitreous hemorrhage in one eye, and there is sponge-like macular edema on the other eye. Here is a patient with branch retinal vein occlusion, and you can see an anti-VEGF has been given, and subsequently after 1 month, you can see there is complete resolution of the edema. In this patient, again, there is branch retinal vein occlusion, you can see out there on the top in the fundus picture, and so he was given 1 dose and then 2 doses. In fact, this patient needed 2 doses of anti-VEGF injections. Now, This is a case of asteroid hyalosis. Now, what does this mean? These are not hard exudates. The hard exudates are very different from this yellow out there. These are basically floaters in the vitreous. They do not affect the vision, and unless and until they affect the vision, you're not supposed to do ideally anything out there. Okay, so we did an OCT scan out here, and you can see they are basically like asteroids falling from the sky. So this is how the report will look like. That's why it's called asteroid hyalosis. Now, what does the ADA say? There is improvements, includes the widespread adoption of OCT to assess the retinal thickness and intraretinal pathology, and the wide field fundus photography to reveal clinically silent microvascular lesions. So this is the statement from 2017. And to conclude my talk, OCT is a non-invasive imaging modality. It can perform micrometer resolution cross-sectional images of the retina in a precise, reliable, and a reproducible manner. It may assist a patient in selection with DME, identify what the treatment is indicated, who can benefit from the treatment, guide its implementation, and allow monitoring of the treatment response. I'm thankful to my staff. That's the Carl Zeiss high definition Sirash machine out there, which has been seen. Thank you so much.
Thank you. Thank you, Dr. Kiran Shah, for such an exhaustive presentation on OCT.
Thank you. Yeah.
Really like your talk. You're lucky working in an ophthalmology institute.
I think, I'm sorry, I just interjected out there. It's the only ophthal institute across India where you have a diabetologist sitting inside.
Yes, and I appreciate
this is the other way around.
Other way around. No, fabulous. See, nobody is presented data. I want you, your pioglitazone data on macular edema. Now, I have another take. Now, the increasing use of saroglitazar. Now, just want you, and you have the idea to look at patients if they're on saroglitazar, and look at even if they can. That's one request. The second one is you have to listen to Sundar Modaliar's lecture on SGLT2 and what can happen in the retina. Okay, his hypothesis, like how the first time when SGLT2 came in and they said, you had two hypotheses, one from Sundar and one from Dr. Elifaran. So Dr. Sundar was there a couple of years ago in Bangalore, and he presented his retinal hypothesis. I think that could be the reason why they're working with SGLT2. That also is a very interesting study. Thank you.
Thank you, sir. I have used everything out there in my slide you have seen. It's almost the same. Yeah, so I think that was the question. What we have seen is 15, 30, 45, 60, even 90 milligrams of pioglitazone has been used, but with 7.5 not so common, because per se 7.5 came very later on. But initially when the triple drugs were used, it was typically 15 milligrams. And unknowingly, in order to increase glimepiride to 2 milligram or 4 milligram, the glitazone kept on stepping up. Okay, and that is the reason we kept on seeing lots of patients with diabetic macular edema.
Unfortunately, government has banned 7.5 milligram combination and 15 milligram.
For Indian, they say that it's as a combination therapy. There are many cases where both of them being
No, as of now, no. I don't know about the combination part of it, but it's still not available to my at least understanding.
What I already see is that if you combine in the therapy, you are giving SGLT2 inhibitor.
If my patient has got diabetic macular edema,
yeah.
glitazone is out. Any dose, irrespective. Then you use SGLT2 inhibitor or anti-VEGF or laser or whatever needs to be done has to be done in order to prevent the vision loss.
So you want to say that pioglitazone should be banned in every
I am not saying it should be banned. It's one of the very good insulin sensitizers after metformin, but it needs to be used in the right patient. And if you are going to use it, kindly monitor. Certain patients who gain weight rapidly, suddenly anemia is there, suddenly peripheral edema is there. These are the typical patients you need to intervene. No. What I said is once you start glitazone and you're observing your patient, rapid changes in his overall clinical condition where you get weight gain, edema, anemia, all those kind of things, you actually scan for retina.
Your question, whether should take a fundus. Every diabetic patient we have to do it once. If he has retinopathy, do it. So follow the same routine. Not necessarily you have to take a fundus. But take a fundus.
Fundus picture. You can use. Yes, 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 yes,
Take home point is a shorter duration,
yes, yes.
less than 5 years.
See, I'll tell you something. I completely agree with you. No retinopathy you should use. The only difference is you need to have a backup of an OCT. When you're talking about diabetic macular edema, by even AI or whichever machine it may be, or even a normal you're not going to do it even with the best ophthalmologist or a retina specialist. You need to have a backup of an OCT. So that needs to be kept in mind. I have got all this data because I'm working in an eye hospital. So subsequently, the scans keep on coming.
That is what I want to say is that what are the silent clinical features that we can look? Number one is less duration of a diabetes. Fundus photography is not showing any retinopathy. Those patients who are along with insulin, if you are supposed to give, then there is incremental chances.
Yeah.
Those patients who have a high triglyceride, and
Perfect.
again in that cases also we should not use. Okay, there are the things.
So I am very
obese
happy.
patient.
I'm very
okay,
happy that you use the word triglycerides, to be very honest.
Yeah.
Even if you look at the ADA statements, they say if it's beyond 500, you're protecting the pancreas, you're not protecting the eye.
Yeah.
So nobody puts somebody on a fibrate. They just keep on promoting statin, statin, and statin. But here we have seen even with 200 or even with 250, these are the hard exudates which actually go into your eye. So why not treat with fibrate and prevent vision loss?
Yeah,
Completely
so
agree.
these are the features actually. Look, you are working in such a setup where you have everything, I would like to say, in place.
Yeah.
But people who are remotely working, or if they have just fundus photograph, then I think so these silent clinical features can help them.
Can definitely, definitely. But the most important take-home message, irrespective of my lecture, is start screening your patient for a fundus.
Yeah, perfectly fine, perfectly
Because
fine.
unless and until you scan your patient for it, there is no awareness about it. Even if you say, as we were discussing before the initiation of this particular session, the patients say, I can see everything. It's completely asymptomatic. I have 4 papers published. The one is called Diamond Study. The second one is called Diabetic Retinopathy and Cardiovascular Disease. It was an oral presentation at the ADA. We predicted even whether the PTCA or whether the bypass is good if your patient is having diabetic retinopathy. We have done it with stroke. We have done it with even with the diabetic foot, multiple papers. But to be honest, when you talk about awareness, including physicians, if I say how many of you all actually check for retina or ask your patient, let me see how many hands go up. So ask internally.
Every patient.
So very happy.
So this fundus.
Exactly. When we started, there was only one hand.
What I see, fundus photograph is an ECG of a diabetes.
Yeah.
So
You have an opportunity to non-invasively see the vessels, and these are the micro vessels. A cardiologist looks into only the epicardial coronary arteries, the larger vessels. They don't see the micro vessels. There is something called, that's where we see.
So that is why I see on a fundus photograph, I use Remedio since last 2.5 years. Before that, I also used fundus photograph. So, but this microvascular retina, when we see that they are showing a retinopathy, the microvessels is showing. So, at that point of the time, it is the insulin resistance predominant, and we really want to target that insulin resistance. And I think so. There are 2 drugs available. One is this pioglitazone, and second one is the GLP-1RA. Which target the hepatic insulin resistance. Okay, then both drugs have an issue with probable issue with the retinopathy. Okay,
No.
yeah, of course, higher blood sugar level, of course, it dropping down. It's retinopathy. It's not so. But the point is that I would like to say that I request you that came out with the silent features where we can use that drugs. Okay,
Sure.
I am a huge fan of using pioglitazone as well as GLP-1RA.
Thank you.
Do we have any more questions? No? Okay. Thank you so much, Sanjay Reddy sir. Thank you so much,
Thank
Kiran
you.
Shah sir. It was a great
Thank you.
interactive session. Thank you.
Thank you.
इसको चार्जिंग को लगा असं क्विट पेंटर असं झालं दुसऱ्यानं
Hope it's audible. Yeah. Chalo, wonderful. If we can, ना गुरु तो आप हो ना सबके. अभी 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 आप मार्गदर्शक मंडल में आ गए. Yes, Lal Krishna Advani of the group. So I'm really happy that we have mentors now. मार्गदर्शक मंडल जो पहले थे अपने इसमें. So good morning everyone. दो सबको बुला लो ना एक बार. विरल भाई बुला लो बदनाम 6-12 से बता. हाँ मेंटर जी. So, good morning everyone. I'm really happy to see you all after, I guess, 2 years. We lastly met in Bangalore, our D-Genius group meeting. Almost, I would say, 50-60% of us were there. And after 2 years, it was very difficult to keep that momentum online. Though we initiated some of the things like awareness series in hypoglycemia. The wonderful idea that was given by Bansi sir, and it was Diabetes India Highlights. Earlier we kept the name Best of Diabetes India, but later on it was Diabetes India Highlights. And this time we are more serious as we have more mentors now. Earlier we were thinking what to do about the D-Genius group when we decided that there would be a constitution and age less than 40 years will have to exit the group. But now we have the option, and this is what my idea is, that who are exiting the group, they can be the mentor of the group for different projects. Like this year, what we are planning, one of the most important thing, and this is one of the biggest responsibility I would say, because Diabetes India newsletter, this is what we are planning, and Bansi sir is giving this responsibility to D-Genius group. For that we have Bansi sir itself. So I would like to request him to talk about D-Genius newsletter first. Sir, so what are your plans and what he is thinking, what is his vision for our D-Genius group, and where he wants to take it?
Thank you, Rutul. So the idea was, the young doctor of Diabetes India. Diabetes India does not mean only an organization. I am talking of any diabetologist of our country is a part of Diabetes India, considering that. So I am not just trying to differentiate you from some RSSDI or from some other endocrine society. It is like the young diabetologist group of India. Let us create a D-Genius, and that is what the Diabetes India as an organization can support you. That's number one. How this idea came to me, because in SPAD, they had a similar type of a group, which is spelled as a J and with ENIOUS, where the young pediatric diabetologists, they form international group, which is on Google, and then they meet and they all do under the SPAD. So I thought of that Indian young diabetologists should make a group. Now, whenever we make any group, somebody will ask what is our mission, what is our vision, why we should create a group, what activity we should do, and as a senior, what you are going to do. So as a Diabetes India secretary, or as a person who is practicing since last 25 years as a diabetologist, what I think that a young diabetologist in India, because they are the future, and as we know, the issue of diabetes in our country is increasing, whether it's a type 1, type 2, and many other problems of this. So many things which can be done by this. We have kept that better that if we keep it below the age of 40, because somebody who's above the age of 40, he's already a well established, more than 15 years of his practice, and he should be now in the in main group. So that was the reason. If we can keep it below 40, but it is all up to you, that's not the problem. The D Genius can do many activities where Diabetes India can help you out. Like one, I suggested you that let us start a diabetes newsletter. It could be Diabetes Voice of India, it could be Diabetes Times, it could be D Genius Times, something like that. And the information can be, every month. It could be once in 2 months. We have already like RSSDI newsletter, so we know that AMI is a part of it. Last time only we decided the editorial board of RSSDI. So similar way, a different format. Now RSSDI newsletter is a different because that gives you the information related to RSSDI. It is not related to mainly diabetes, because we have 21 chapters in India. What activity they are doing, we want to club it into the RSSDI newsletter, and then again it should go to all members of RSSDI. Now, as I told you, Diabetes India is a research trust where only few of us are the trustee of it, and it's not society, it is a trust, but we believe that all the members of who is practicing in India as a diabetes is a part of Diabetes India. So we have a larger group, maybe 30,000 doctors are part of Diabetes India. So what we can do is we can start a Diabetes Times, a D Genius Times, or whatever the name which you want to create. We start with a newsletter which will be a information or news related to diabetes. It could be any international news, it could be any national news, it could be related to some research, some outcome, or some activity, whichever you can plan, which could be first start with a 2 page, and then it can be grown up, and it can grow up to the level of, because I'm sure many of you know, IDF have a book called, a magazine called Diabetes Voice. So it can grow over a period of time. For once in 3 months or 2 months, it could become like a Voice of India, something like that. That's one idea. The second thing which we were thinking that we should do something else also, like creating some registry, creating some data, some real world, something which we can do. Now, problem which we had seen that it is very easy to discuss. When we discuss in classroom, I'm sure Archana knows it, me, Archana, Durvi, like for type 1 registry, it's very difficult. So nobody wants to share the data. And it is, to be very frank, it is not like that I don't want to share the data. On other side, I don't have proper data. That is the fact. I don't want to share because I know that it is not properly done at my level also. This is the fact, and which we have to accept. It is true. We know that we are doing since last 20 years, we have electronic medical records, we have 25,000 patients, we have 100,000 patients, everything, but what we have. At the end of the day, you will find in your database only, you will find you have name, age, you have address, you have sometimes their A1C is done, sometimes not done, you have not done follow-up, you have not done, patient had not come to you, you have not written the medication, the next visit your person was not there in clinic, many problems are there. When we want to collect the data, then somebody will come, who will do it? We don't have the staff, who will pay for the staff, how the research can happen. So how Diabetes India can help you? If you create for one particular thing, like suppose we want to have a hypoglycemia, and patients who are getting admitted, your patients getting admitted for hypoglycemia, that's a severe hypoglycemia, and you just try to collect the data of that. And at one particular place where you are sending the data at one place where you can collect all those data, the Diabetes India can fund it for that registry, for taking care of the data which you are sending in, because ultimately it has to be converted into a paper. So for that, a Diabetes India can help you out. So this organization who is doing a conference, with every conference we save some lakhs of rupees. What we should do, that lakhs of rupees should be utilized for creating something which is really good, where the name of, again, who will be the author, who should write it, there are many challenges. So that we have to sort it out. Like suppose out of 100 patients, somebody who had sent 10, he should be the first, 8 should be the second, and then first 8 names are there, and then extended group of 30 or 40. sort of things you can decide. That is one thing aspect. You can create a data on pregnancy, diabetes in pregnancy, hyperglycemia in pregnancy. Again, the type 1 registry you can partner, which we have already started in RSSDI. Mithun had come out with the idea of like semaglutide registry. So there we can become partner. So any idea coming in your mind, you can do it. Just before some time somebody was asking that how I should start the research, and I just asked since how many years you are practicing. He told me just 12 years. So let us do in 2010 when you started your practice. What type of patient you used to see? It is what was their average A1C of the time of diagnosis, their BMI, their anthropometric data, family history, and now you compare it after 10 or 12 years. What type of patients now you are seeing? What is the newly diagnosed patients in your area? How they have changed their anthropometry, the age of the diagnosis, HbA1c, something like a very simple thing which we can also do. So many things can be done under this, and I must congratulate here Rutul that he had created a very good book. Rather, I will say it's a booklet with the case reports of hypoglycemia, and many of you have contributed in that case reports or in a book of hypoglycemia. More than 30, I think, 35 case papers were, and still there are few more. Yes. So, 35 different type of clinical cases, scenario, real life from different doctors they have contributed, and today we are going to release that book, and I'm sure it will be very useful for the other clinician also, because it's a real world data and in a real life scenario how patient is developing hypoglycemia. There are many companies who are also there to support us. So suppose he is also having one idea that using one type of insulin, getting a patient how much time in range. So one thing this year in ADA, one of our paper is there is a hypoglycemia is hyped due to sulfonylurea. So it is inappropriate use of sulfonylurea causing more hypoglycemia rather than only just writing that sulfonylurea causes hypoglycemia. It's a similar way that insulin will also cause hypoglycemia if you will not use in proper dose. People are using glimepiride with a 8 milligram. They are not using with constant monitoring, regularly monitoring. And suddenly one day you find the patient is in severe hypoglycemia. So if you do the continuous glucose monitoring, we thought of should we do one in Gujarat, and at Ahmedabad we decided that those patients who are on sulfonylurea, try to find their A1C less than 7.5 and do CGM. You will find that most of them have hypoglycemia. Below 7.5, to achieve with sulfonylurea. And then try to modify the diet and medication and everything. And you again repeat it. And you will find that you still can avoid those hypoglycemia, even patient is on sulfonylurea. So the point is you are doing one paper, you are trying to create that sulfonylurea just by writing randomly and putting the patients on 2 milligram, 4 milligram, and if you are achieving HbA1c of less than 7.5, you will find invariably there is a hypoglycemia. May not be like 25% of the day patient is going in hypoglycemia, but 5% of the time, 6%, which is not acceptable, because more than 5% it is not acceptable. But when you modify the therapy, you change the way you want, and then you will do again after 1 month or 3 months, and still A1C is less than 7.5, you will find that you are actually avoiding hypoglycemia. So appropriate or a smart use of sulfonylurea can definitely avoid the hypoglycemia, and that sort of a paper can be again written, and many sulfonylurea company in India, they want to support this type of idea, because we are struggling between newer oral anti-diabetic agents versus older anti-diabetic agents. So many things can be done with the D-Genius group, young diabetologist, and you are the future, and I am sure you must have more idea and more technology. You are advanced, you can do more things technologically. A few more things which are coming in our country, like continuous glucose monitoring. Now we have our own Indian company who had come with a continuous glucose monitor. So we can also ask them to support us for doing more data for this time in range or with some other drugs. Thank you.
Sir, one of the things that we want to clear, that we have some of the doctors who are age more than 40 and they were previously part of, we want to clear this, that I have an idea that I have already shared with them, that for every group, we are creating 3-4 different kind of groups for like a newsletter committee. they will be mentoring this thing. Like Dr. Ami is part of RSSDI newsletter, so she can help in newsletter to those D-Genius members. So this is how we can involve them as well, and we'll keep a separate group of mentors who will keep guiding on. So
I fully agree. Nobody wants to leave any group. The issue is because we are closely interlinked. We all are close friends. You know, you don't want to leave that group for reason is very clear. But I think this is the time that we should gracefully leave thing, because otherwise new people will not come. Tomorrow a time will come that you will also become 40. Otherwise nobody will join this group. So you have to get people who are now 25. He just started the practice. You have to identify that this is the guy who is just now passed out with a diploma diabetes, a DM endocrinology or MD medicine, who is interested in field of diabetes, and you have to take him in this group and you have to call. And tomorrow when you will be growing, now I mean, you are also 35, probably after 5 years you have to also leave. I mean, that is the what we should do it. So gracefully we all should leave the group. I mean, I'm not saying that you don't keep anyone here, you keep everyone here, and you do whatever the best which you want to do with them, involving them in a newsletter and all those things. But what will happen, you know, after 5 years or 10 years, you will find that most of you are like with 45 or 50. You will not find that a 25 or 30 year he will come in your group and will have, because then he will feel that, you know, or she will feel that these are senior people, they are talking and they are not involving us. So they will create a D-Genius junior group, you know, and then somebody will come with D-Genius junior group. So that should not happen. Am I right? So I mean, the best thing is, this is because a new group and you don't want to leave this group. I mean, so that is fine. No, it is not like that, kicking them anyone. I'm not against it. I'm just telling you, because this is what gracefully everyone has to. I was thinking rather we should keep it 35. But the problem was that if we keep it 35, that most of you will be out. But first what you should do is you try to get and identify the young diabetologists, young doctors who are not getting supported. Today they are not getting support. You try to identify in India those who are passed out, newly passed out DM or diploma diabetes, who had done the RSSDA course, MD medicine, identify them, try to involve them, and next time we should fund them to come to the meeting. We should try to get them, 100 more new doctors should join the group. And then slowly they should take up and you start leaving the group. That is the right way of, I mean, for this D-Genius. The future of D-Genius should be like that. So I am not saying that you kick out at this point of time. Please don't misunderstand me for that. Thank you.
thank you very much, sir. So
Now we'll start with our first session.
please come. Yeah.
मैं 2 साल young हो गया हूँ. Sitting with young people, you kind of get that energy, which often is missing after you age up. So when I was in England, there was this concept called ABCD, the Association of British Clinical Diabetologists, and they started a registry. The registry was every person has access to his data. So we are going to start an app which will be functional by end of June, called India Matters. The first project is going to be on oral SEMA. So we are going to collect data on oral SEMA, and say Ratul has say 10 patients on oral SEMA. So Ratul will have access to his data. कल को रतुल को उसको कहीं IDF में पोस्टर डालने का है तो that is his, and he is also part of the nationwide data as well. So you get both things out of it. And every publication that will come out of it, all the contributors, even they have given 2 patients, 3 patients, name will be there. If that publication will have a problem taking contributor's name, I will not publish the data in that publication. So that is surety I can give you. So once we start this nationwide movement, because we are all private practitioners, I'm sure there is no government doctor here, and we do not belong to a research unit, and that is one part that we miss. because we have to earn our livelihood also, absorb our practice also, collect the data also. Then the data fragment is very small for any good association to actually take the data. So if we could collate something like this, it will be very good. The app is ready by June 3rd week. So ITI एक week और पकड़ रहा हूँ. June end तक the app will be up. So we'll start with oral SEMA. There will be learning lessons. I'm sure we'll learn something. We have to be tweaked, and we'll tweak according to the needs, and then try to grow it up further and see what else we can come out of it. So that was one project I discussed with Bansiba, and he was very supportive. So we thought we'll come to the DGenius group and ask if people were interested. We will start that. That was it.
I'll ask to everyone that whoever is interested in this registry after 2 or 3 days after going back. And for the next topic, we have Dr. Archana Sada ma'am, type 1 diabetes management beyond guidelines. I recently visited her center before, I guess, 1.5 months, and I was so much impressed that I was only, that is the only thing that always come into my mind, that we should have this focus on anything when we are doing anything. So you are into so much into anything. So please, ma'am.
I have brought up the slides. Use this. Right. Good morning, everyone, especially Dr. Bansi Sabu. Before we start, I was saying outside that we should call it the Genius Group, take away the D, make it the. So these are very genius people. At young age, you are being mentored, and my compliments to Dr. Bansi. Not just you, although we are at the same age, but I would say he mentored me as well, because I had the passion, I had the work, but I never connected. And he really pushed me from day one. He brought me to every forum. He made me speak. He made me present. He made me put the data down. I had everything, but I would never communicate. I was very happy doing my own work in a little village, very happy that my patients are happy, I'm happy, community is happy, that's it. So I never wanted to really, I was not aspiring to connect with the medical fraternity at all. And that is something he brought in me, and I'm really grateful forever. I see you as my mentor. Thank you so much, Dr. Bansi. Yes, so my topic, and Rutul, what he told me was that he said, ma'am, no scientific topic. I want you to show them the other side of type 1 diabetes care, and that is just to sensitize you. So there's no science here. You are the best people to know the science. There are amazing books, there are amazing guidelines. RSSDI is doing a great job with a lot of data bank there on each topic. If you wish to, go ahead on the learning platform and learn more about type 1 diabetes. In your day-to-day practices, unless you're very typically working with type 1 diabetes, you might see very few patients. In your average clinic, it might be just not even 10% of your practice. That's okay. We want to emphasize that every child matters. So even if you see one child or adolescent or adult with type 1 diabetes in a week or in a month, yet it is very important that one person gets what that person deserves, because type 1 is different. It is not the same. It is not like that one chapter in our entire textbook or entire MD medicine that we learned. It's a life which lives differently from type 2 diabetes, and that is what I'm here to sensitize you about. So these are a few of my kids, and this is how we stay together. So what is there beyond guidelines? One is, of course, low limited resource settings. So many of the children, see, if you have somebody who can afford it. So my first point is that you will have people's daily wages workers. They will come with a child with type 1 diabetes, and you feel sad for them. You are empathetic, sympathetic. But at the end of the day, you say, okay, what can I do? This person cannot afford insulin. Maybe they're illiterate, right? They're going to tell you that I cannot take more than maybe 2 pricks. I don't want 4 pricks. And you'll say, okay, this is the guy. They're anyway illiterate, they can't afford it. Let me put them on a premix insulin twice a day, at least the child will survive. That is the first point I would like to drive home today. That it's not survival we are looking at. It's not enough to survive. Just because they are laborers, they don't understand, they don't have money, that is not a reason that you help them to survive with the premix insulin today, and they die with complications before the age of 30. When I started work in Aurangabad, and I started with my practice, and there was not a single person with type 1 diabetes. I asked everyone, where are they gone? I asked all the doctors. They said, are you crazy? Why do you want to work in type 1? They don't survive. They don't last more than 30 years. Nobody lives beyond that. And they end up with complications. I said, why does it happen only here and not in the rest of the world? And then we started picking up. Today, UDAN, which is my organization, we have 1,000 young children and adults. My 100 kids are married, 200 are working. I have grandchildren, they call me Aji, which is like a grandma. So it works, right? It was just because we were not thinking it can be done. So my first thought to you is, it can be done. There are so many organizations where you can actually reach out for insulin. There are so many pharma companies. You can ask them for basal bolus insulin. Do not compromise with the kind of therapy. If you write a premix, 100 people will follow you tomorrow and write a premix. Do not justify it with your pen. Condemn it every platform where you can. Do not, only condition I can think of. I'm currently writing a part of the SPAD, low limited resource setting guidelines. The only place, like in African countries, they said, we don't have access to food, so how can we think about access to insulin? So the only recommendation where premix is okay is a step till you get access to at least regular and NPH insulin, where you can create a basal bolus. So it could be a life-saving step for a few weeks. So if you ever write premix, do write this is temporary. This person has to be shifted to a basal bolus of some kind, right? So that will send a message to everyone who sees your prescription. So this is a very, very emphatic appeal from my side, and that is something that is our duty, because we change the way people prescribe. I want you to be sensitive about the insulin. So it's very easy to say they don't understand. I have so many children, they're all daily wage workers. They go to their farm and you ask them, why aren't you taking the lunch insulin? They said, if I come back for my lunch, I miss 350 rupees, which sustains my family. So do you let it go? No. So just one, right? You have one patient, 2 patients, 10 patients. Find a solution. We have children who are getting pricked in the lunchtime by the neighbor's grandmother, or the nearest pharmacist, or the nearest school teacher. So there are various solutions we have found, but all my kids today take a lunch insulin. In the remotest of villages, it just took a little effort. But once the system was set in, these children are thriving. So that little effort can make a difference. You cannot skip the afternoon insulin and get a great HbA1c, and not just HbA1c, the growth. It's not about living, right? It's all about surviving, thriving, growing, and that is what makes a difference. So I'm just trying to say that we can make a difference. They come with low literacy. We're talking about education, education, education. Everywhere it's about education. Do we educate our low literacy patients, or do we say, कि इनको तो समझ नहीं आता? They don't understand. We gave them a class, we gave them a paper, we have a booklet, we have a video. Do you think they learn? So there are people who are visual learners. There are people who are audio learners. There are people who are doers and learners. There are people who will not learn in any other way. You have to handhold them. But is it okay to not learn? So I will just share how we do it, but a moment later. Can this girl count carbs? She can. She lives in a village in a tin roof with, I think, 100 square feet of a home. Her nearest road from her home is 7 kilometers. It takes her 4 hours to reach us. But this girl can count carbs, because look at her plate. She sent her photograph. Because they make a chapati. For example, in my clinic, even the most illiterate child's mother makes a chapati with 24 grams of atta. Right? So they make double 50 grams ki chapati, which is a 2-carb chapati. So they have a set, they all bring their vatis, with what is a katori, a bowl. They bring their glass, spoons, plates once. And we have all these grains there. And they will measure it, go home, take it, make a chapati and see what size is their chapati of 50 gram, that is carb counts. So all my patients would make a list of everything they eat. How many things would you eat? You would eat 100 items. So we carb count those 100 items, give them a list. So every time they can't think, I understand, every time they can't calculate. But the routine food that they eat every day, the tiffin that they take to school can be carb counted if you handhold them. It takes effort once, but it changes their lives. It's not about being a doctor, it's not about being a patient, it's about a child's life and growth. And that is why this effort is worth it. And that is what I wanted to emphasize here. You are thinking from a very caring point of view. You think the parent wants to take care of their child, and that is why they would listen to you, right? But believe me, there are parents who don't want to take care of their children. I have mothers who have left home because their child was too much to take. There are fathers who have left the mother and child because it's just too much to bear. So do understand the kind of exhaustion parents can feel. Just having to take care of a child. There's no money. There are 3 more kids. And even if there's money, I have some very, very well-off parents who they say, anyway, she's going to die one day. Just let it be now. Why matter? So most parents, I'm very sorry to say that, but most Indian parents see kids as investments. So if there's no return on investments, if perceived return on investments, they don't want to invest on their children. This child is not going to grow up, learn, earn, give us a pota or a dota. I mean, that's the prime purpose of life, having a kid, because they'll produce a kid for you. Or take care of us in their old age. Then what's the child's use for us? And I have parents who tell me, so it takes me 2 years to convince them to take care of your child. I offer them saris and clothes and food and free travel and things, and let your child live. But within 6 months to 1 year, when they meet other peer group and they see role models, and then it changes. Then we don't have to do anything. It's just an investment of first 6 months because it's a new idea. Please understand, it's the whole world has fallen for them. So just be kind, be there in their shoes. And somebody whose tummy doesn't get filled is not going to think of lofty ideas of great parenting. Right? So that empathy, if we cannot understand, then we would let go and say that I educated them, I offered it, they didn't come. So just handhold them, give them a year, and then see how they will respond to you. There's so much fatigue to depression in young people. So I have a girl who's a billionaire, they could buy my entire town, but she wouldn't go out. One girl was not taken for a picnic by the teacher. She was an amazing singer, classical singer, 10th grade. The teacher said in the entire class that, okay, Chaitra, you have type 1 diabetes, I'm not taking you to the picnic. That girl has not sung a single song for last 10 years. She's under therapy. She just stopped singing. She internalized the whole thing so much that she stopped singing. And I mean, that was 10 years, and now it's been 5 years since then. Now she has again started singing. She moved to US, she did her MS, she got a scholarship, and it took her such a long time to realize that I'm okay with myself. But how can we relate to that? It's so difficult to accept your own self when you're different from others. So step into those shoes, especially a teenager. What does a teenager want? To be accepted, to be liked, to be, I know, not only on the social handles, but also everywhere. So anything that is different makes them feel so unaccepted. And unless we understand that, are all the education, the best basal bolus insulin, the best CGMS, the best pump in the world is not going to give that unless we take care of this angle of our kids. So I just wanted to offer a few solutions. So I believe to every problem there is a solution. If you want it badly enough, it will just strike. Puri kainat जुड़ जाती है. So that way the solutions will come to you. You just want to have it. So this is our little earthen pot. I'm sure you are using some of its kind. But we did this 15 years back when one summer everyone came with a very high sugar and we realized the temperature was above 40. So this is validated. Anyone who wants it can look it up on YouTube, contact me. So we did a very good scientific valuation with it. And this is pot and pot, costs 150 rupees with a local potter. That is sand between the two layers, so that evaporation increases, needs 3 glasses of water. Any local potter can make it. And this is great not only because there's no fridge, but people can buy a fridge, but when there's no electricity, there's again power cut downs. Or people, I have kids who are living in the hostel, and that's a very heartening story I want to share. Look at this boy, he's Nakul, comes from a very low resource setting, and he went to a hostel, engineering hostel, after a lot of hard work. And he said, how can I give water to this pot now? Right? So he had a pot, but he did not have a watering, who would give it? No? It's in the hostel room, and he's in the college. So he designed this thing, 5-liter can, he put a timer on it, and like a drip irrigation thing. And so every hour it would give 100 ml of water and the pot. So this is the boy's own design, and he innovated it and kept it in his hostel room. So you give them an inch and they'll go a mile. That's how creative and innovative they are. That is the kind of will. This boy comes from a family where father is a laborer, the mother is working on the streets, a scavenger. And this is what he's doing. So that's the kind of power that motivation can have. We were talking about education. This is just sharing something we did. We use a program called Mighty Moms, where we convert D-moms into D-coaches. Right? So these are mothers of children who have type 1 diabetes. They are not highly educated, they're just literate, and they are trained and they take care of them. These are some of the games we've made in the local language, and there are hundreds and hundreds of such games, innovative games, and when they play with this, they learn. So every word, whether it's a ball game or spin the donkey kind of thing, ours is a HbA1c pinning game, blindfolded, this, that. All kinds of things you can do if you desire to do so. Ultimately, you need peer groups. All of you, my last message is create peer groups. Even if you have 2 people with type 1 diabetes, reach out to the nearest NGO, nearest organization. Don't think of a typical mindset, my patient, my patient. They need to reach out, like you have come together for a better care. Same way your children need to reach out to each other's kids. And more picnics, more fun. I did a survey of all my kids and asked them, what do you value most when you come to Udan? They said the fun. Everyone, I said, education? Okay. Free insulin? Oh, okay. What is invaluable then? I was like, what? You don't want education? You don't want free insulin? We want friends. We love Udan because we hug and we kiss and we dance and we do all kinds of things. That's what we come for. Right? So the kids drag their parents, let's go to them, because it's a play thing. So they need happiness, and that makes them want to take care of their diabetes. That is something not given in books, and hence beyond guidelines. That is what I wanted to talk about. Another thing is you need money. So we raise funds. Please reach out everywhere, anywhere. But if you start seeking, you'll have to. So I have a program called Adopt a Child with Type 1 Diabetes. I beg everywhere. My hand is always like this, give me, give me, give me, give me. Earlier I used to feel, very ashamed. How do you ask for money? Now my children are ashamed of me. Mama, wherever you go, you're always begging. I said, yes, that's what I'm going to do. Every forum, every person I meet, I say, oh, you have money? Do you want to adopt a child with type 1 diabetes? That's all I do, all the time, unashamedly, and I'm very happy to do so. And I shall continue doing so. Was that the last time? Something went wrong? Just the last slide, and I go. Yes. Yes. Okay, so just one slide. So if you do have a clinic, it could be 1 day in a month, 1 day in a week. 1 day I do 2 days a week. 4 days I do professional practice, 2 days I see children. But I started with 1 day in a month, then 2 days in a month, then 4 days in a month. Now it's 8 days in a month. So you can just have a system which is a happy place. And a safe and a happy place is where they will come to. Where they're criticized, where they're treated differently, that is a place they will not want to take care of their diabetes. So we want to create leaders, and this is just last one girl that I would like to introduce you to. She is Sanika. Her mother makes chapatis. Her father is an alcoholic. Family of 4 children. But today she is a diabetes educator, and a very good one at that, at our center. And I mean, she drives the fastest gadi that you can imagine. But all this came with no resources, but just motivation and the will to do so. So every dream can come true. So when you are treating their diabetes, also treat their dreams. And that is my message to you. Thank you so much. Yes.
Thank you very much, ma'am. It was really an emotional thing, and it's been always for me. When I visited her center, I have seen that every person working at her clinic is rather a type 1 patient or a relative of a type 1 patient. And this is quite unimaginable for me, that how it is possible. And she has made a world that we can't think of. So thank you again, ma'am, for making part. So for Bansi sir, are we launching now? You want to? Yeah.
Everyone cannot be like Archana.
Very true.
No, I tell you, it is very important thing. And message why I am telling everyone this thing. Because for her, it was her patient or whatever the reason, but otherwise also I feel that everyone can't treat type 1 also. Type 1 is not what you are knowing from the guidelines or what from knowing from the textbook. We all know how to treat type 1. We all know how to treat diabetic ketoacidosis. Many of us who does not know, they can go and read it also. So it's not like, it's a very simple science. Still, decay management is not changed over last 25 years. It is same. What you were studying before your 25 years, it is same. So type 1 diabetes patients, they continue to move from one doctor to other doctor. The problems, they feel always that they want cure, which they are not going to have. And other side, a diabetor endo is going to charge them for thousands of rupees for some time consultation, and the patient will not go to the doctor again and again. So those who are interested in taking care of type 1, one thing I request them to know from Archana is they have to take care of these patients lifelong without any consultation charge. So I mean, that is one thing very important. Otherwise, it is not possible that you will have. So registry, only those can participate who are going to have the patients which will be staying with you, because you are not going to charge them, and that's the reason they will continue to come to you, and then you can fill the data with the registry. So what next talk with Durvi, she is going to talk about the registry in type 1 diabetes. A type 1 registry cannot be completed, I mean, because you are not going to have the patients. A one diabetologist may say that I have 2,000 patients in last 25 years. I believe that 22,000 patients might have come in last 20 years, because you are a diabetologist of your city. Anyone who is diagnosed with type 1 diabetes would like to come and see you also as a 1 or 2 times or 3 times, but he or she may not stay with you, because for a 5-minute consultation, staying in your waiting room for 2 hours, and then you are just seeing his report here and there, writing 2 units here and there, patient will not stay with you. Believe me, patient will not stay with you. Patient will change. He will go to some other doctor. He can't be with you. Unless you treat type 1 diabetic patients with lot of sympathy and empathy both, along with lot of education. Half a day you have to educate the patient. A lot of things are required for a type 1 diabetic patient. Patient will not stay with you. And just by increasing 2 units here and there, for which he is staying with you or waiting for you for half an hour or 2 hours or 3 hours, he will not stay. So type 1 registry, please enroll yourself only if you are treating diabetic patients, type 1 diabetic patients, free of charge, or you are ready for doing it, or dedicated for type 1, then you do. And everyone can't do it. I mean, it's very also true. Or you can keep once in a week. The best thing is, I mean, on every Saturday, half a day, you are dedicating your time. Like first time you are seeing the patients on any weekday, you charge the patient as your routine consultation charge, and then do that every 3rd Saturday. I am going to run a free type 1 clinic in my OPD. That is the best way. So every third Saturday, there is a free OPD for type 1. So now you call these patients, okay, every second or third Saturday, you have to come to my clinic. We don't charge. You don't have dietitian, you don't have diabetic educator, you have trained some type 1 diabetic patient who himself is a type 1 educator, you can make him, you can call the pump guy, you can call the BD, insulin syringe guy, you can call someone who is from the glucose meter. So now you have a team of the persons who can educate the patient, and you can dedicate your half a day or full day with these patients. You are sitting with their parents, you are sitting with the relative, you are talking to them, you are educating them, you are seeing their abdomen, whether they are developing lipo or any other problems. You are educating them for pump, you are educating them for insulin technique, you are everything you can do in that. So I mean, once in a week, once in a month, once in 15 days, but do it on that particular day. You make the complete data also. If you are part of any registry, make sure you are writing all the data also. Try to get their A1C also at a concessional price. Give them glucose meter, give them glucose strips, give them insulin, anything. If anyone in this room needs any support for their patients, getting insulin free, getting insulin syringe, needle, strips, glucose meter, or even insulin, basal bolus, regular, glargine we can give you, regular insulin. You can write to RSSDI. We have from RSSDI type 1 support. You can write directly to me also. We have Life for Child project. They can also support you. And we have already with Biocon, with Vocard, and with Sanofi. They all will give you the insulin directly through you to your patients. So that much I can tell for that.
Great. So before moving to the next session, I'd request Bansi sir and Manoj Chawla sir is coming. Okay. So I'd request him to launch our hypoglycemia case series book.
You can call some of the seniors who are not the part. Like
So we have Jyoti Dev sir.
Rakesh, Amit, they all can be here.
So please, sir, please.
Please come with
Manoj Chawla sir has come.
Manoj had come?
Ah.
Sharing session.
So Raka and Ami can come. Saurabh also. Saurabh is there.
Purvi is also.
Purvi, come here. So this is what still young, यानी वो तो हम भी अभी यही बोलते हैं। तो इधर आ जा तो भी डीजीएस ग्रुप पे नहीं रहा है। Hypoglycemic diabetes from management. Cases to advance the hypoglycemia in your clinic practice. Joint initiative by Diabetes India is published by RFAC by Ritu, forward by Dr. S.R. Arvind, cases
We'll move forward to the next session of Type 1 Diabetes Registry. What is the need for Type 1 Diabetes Registry? That will come to know from Dr. Dhruvi Hasnani, who has extensively worked in Type 1 diabetes with Bansi Sabu sir, as well as she is also part of SWEET Registry, and she has visited Ulm, Germany for the same, and she has got the training from Ulm. So I'd request her to explain her, what is the need of Type 1 Diabetes Registry.
Slides, correct?
Yes.
So,
Other slide.
till the slides are there, we'll shut the projector.
आप करके दो,
So,
इधर आ
the
जाओ.
idea of Type 1 registry, how it started, the time they are putting on the slide. Somewhere in 2012 or 13, it was Dr. Bansi Sabu sir who had visited the ISPAC. Yeah, they had a SWEET meeting. SWEET is this organization that is one of the largest registries, a worldwide registry. It has around 107 centers across the world. Alright, okay, yeah. So we have the slide there. But then in 2014, I was a very, very young fellow RSSDI learning. Okay. Monday, it was not necessary. Alright, so I was a very young fellow, 2014, learning diabetology. And he said, Berlin jau chai? So I was like, why are you sending me to Berlin? Yeah, alright. But I guess you guys understand Gujarati, Hindi, English, all mixed, right? I'll be using all the languages possible, probably even Russian or Germany. So he said me, he asked me, do you want to go to Germany at that point of time? I was like, yeah, of course, why not? You know, chalo chalte. And I went there, and a group of very, very passionate people working for Type 1 diabetes, but talking about data. Now, it's not our Indian system to even understand data. At that time, even EHR and EMR were not something that we used. We used to use those papers, and for me, it was a very, very new concept that, you know, what are they doing? And then they used a software called Diamax. And it was such a complicated system. Even now, if you use the current SWEET software, it is called DPV, the full acronym, or if you like put the full name, it is something in Germany which I can't even pronounce. So we started step by step. We started with an Excel sheet. They have a bare minimum parameters of, you know, a small, yeah. So they have a bare minimum parameters wala Excel sheet which you fill up. And at the end of 6 months, they give you a benchmarking report and tell you where you stand. You have to fill up these parameters. Say even if you have 10 patients, they'll still give you a benchmarking. If you have 1,000 patients, they'll still give you a benchmarking. They'll tell you where you stand in terms of A1C. They'll tell you where you stand in terms of screening the patients for retinopathy or nephropathy or even cholesterol or even a C-peptide or thyroid screening, and even BMI, height, weight, blood pressure, which we miss doing sometimes in our type 1 patients. So that was our international exposure, and today DiaCare is the Southeast Asia hub taking care of 24 centers across Asia. Now I come to my topic today. Dr. Rutul requested, you know, why don't you talk on the need for type 1 registry? Now, in this time and era, we all use EHRs, we all use EMRs, a lot of us use HealthPlix, people use Docon, people have One Glance, and some of them have their own EHRs. So now, what is the necessity, and why is every association now talking about registry instead of EMR and EHR? So let's talk about that. We don't have a slide changer. Oh, thanks. This is the latest IDF 2021 Atlas data. Very beautiful to understand, very simple to understand. This side is the prevalence data, the other side is the incidence data. Do you see where India is standing in the incidence data? No estimates made. How do you get an incidence data? For anybody and every one of us involved in some kind of research, involved in some kind of epidemiological studies, we all know that we'll need a previous data, a long prospective data to understand where we are standing. So this is one of the important reasons why we need an Indian registry per se for pediatric diabetes. Now I'm not focusing on type 1, I'm saying pediatric diabetes per se. Now there is some Indian data also. We are not saying that India is lacking in data completely. There was this paper by Dr. A.K. Das sir in 2015, and he said the data states that prevalence is 97,000. But he said there are 18,000 children less than 15 years developing type 1. And the IDF data is saying 97,000. Look at the discrepancy in the data. What is happening? Are the rest dying? So we need a registry to answer this question about true incidence, about true prevalence. So now what is a registry? We have to understand this, that there is a difference between EMR and registry. A patient registry is an organized system that will use observational study methods to collect a uniform data, both clinical as well as other data, to evaluate specific outcomes for that matter, for a defined population, for a particular disease. It could be type 1, it could be hyperglycemia in pregnancy, it could be type 2 diabetes, it could be FCPD, anything, any particular disease, condition or exposure that serves one or more predetermined scientific, clinical and policy purposes. Now, it is important to understand policy purposes. We are a group of D-genius. We are here because we have the future. That is what we heard in the last 45 minutes. So we are going to be the policy makers, maybe down the line, 10 years, we'll be electing some of you. We'll be electing some of you in terms of diabetes or even in terms of politics. So we need a registry to understand. Maybe we'll elect Rutul, we'll elect Dr. Vipul, we'll elect somebody either in the field of politics or diabetes. So we need a registry for that matter, specifically to both of you. Yes, yes, ma'am.
That they are making. But has clearly said that we are going to specifically type 1 for like who are ready to treat them for long. It's not just like, yes, everyone is doing, so I want to do it. It's not for one drug or one thing that is going to run for 1 or 2 years. So who is clear by their mind? They can.
In terms of collaboration, when we talk about any Indian registry collaborating with the outside people, the ICMR has a special HCMS guidelines. You have to fill up those forms, and we have to take the permission and intimate the government also that we are sharing our data with people across the world. Yeah. Yes. No, even for an anonymized simple data. Yeah. Good idea, yeah. We should take it up. It's a very fantastic idea. True. It's a very, very productive idea, and maybe we've never thought of it. We can take it up with the Indian Pediatric Association. We can take it up. Yeah. Absolutely. Yes. Absolutely. It's a fantastic idea, and we'll take it up, ma'am, actually. Thank you. So I was talking about an EMR versus registry. The only drawback with EMR that you can think of right now is a long-term prospective data evaluation that does not happen with EMR. Say for example, me at Rudraksh Hospital, we were using some other EMR 2 years ago. We are using another EMR today, and 5 years ago we were using some other EMR, and the follow-up never happens in spite of the EMR people telling us all the data is retrievable, we will retrieve it for you, it is your data, you use it, the thing never comes back to us. So that is one thing that, you know, did strike me when I was making this. But some of the other things was that there is a lack of uniformity, of course, lack of synergy amongst us also as healthcare professionals. Say Puri ma'am might want an X list of parameters, we might want an X list of parameters, and they might not be, you know, similar, or say qualitative analysis ke liye it might not be completely appropriate or perfect. So there is lack of awareness also around privacy and piracy also when we talk about health information and security protocols. So all of us are quite insecure also in that matter कि मेरा data चला जाएगा, मेरा data है कि ना, that is again another story, but you feel that these companies might be using the data. The recent one that happened with Beto, I think it's a controversial thing, but again, a lot of us thought that they are trying to influence our patients, you know, and they might take up the practice, and it's quite normal to feel so. And that is what an EMR does not have the positive side about it in comparison to a registry, which is a very, very close thing, and the data goes anonymized. There is no scope for the kind of advertisements that are given on EHRs. Yeah, so that's the advantage one which I want to point out. So I come to almost my conclusive slides, that why does India need a registry? We know that there is lack of data, lack of evidence. The only thing that we have to look upon as a group of DGenius is planning, allocating budget, planning lab services that could be, you know, very, very uniform, create support system. Kaun karega? We ourselves do not sit in front of computers to fill up our normal patient data out of whom we earn. So imagine you have to fill up the data, like just Rutul is pointing out, कि आप free में देखोगे वो patient तभी long term आएगा, but are you going to sit in front of the computer or give the patient that amount of time, right? So that is the support system also we have to build up, and we have to train the people who are going to do the data entry. Train them and explain them the importance of the parameters that they are filling up. Any one parameter filled up incorrectly is going to affect the analysis that we are doing. So all of these are something that we have to address, and these are also one of the leading examples onto why we need a type 1 registry. It is also going to improve our standard of care. There are good clinical practice guidelines which all of us follow, and you know, they might vary again, they can be different. If, you know, I have to ask Dr. Patriya from Surat, she might give me that, you know, this is something that I do, it is good. Like ma'am, Dr. Sarda was just sharing with us about her beyond the guidelines experience. So those are all very good clinical practice things that we can take it up and try to maybe adopt at our centers, and which can be helpful. Now, some very scientific answers to the clinical data registries, how they are going to play a crucial role. Quality improvement is one thing, benchmarking is another. Clinical research, something the rest of us already present in this room, and the only ones present in this room would understand about how important it is for us to come out with answers to the questions that all of us have currently. Maybe because of the lack of evidence, lack of data is the answer that we give to a lot of our questions. Ke C-peptide ka kya importance hai? There are a lot of other types of pediatric diabetes also which are not addressed. And since we have not seen them, or maybe we don't have them documented, we don't know, you know, what exists and how does it exist and how do you even manage that. So a registry could be helpful in that matter. Cost effectiveness, registry is again quite cost effective. Device surveillance, treatment surveillance, and population surveillance. All of these are very, very positive points and usefulness of some clinical data registries. And again, this is not per se for type 1 diabetes, this could be for any of the other diseases also. Now, some very important questions that that rise in my mind also, and I think it will be in all of yours also. Is there sufficient evidence onto how cost effective and efficacious these registries can be? Yes, there is a lot of data on how registries are useful and how they can be sustainable. There is the T1D exchange registry in the US, the SWEET registry across the world now. There is a Swedish diabetes registry, there is a Denmark diabetes registry, and almost every country has their own registry, not for just diabetes, but also for other chronic care disorders. Our wish for future advocacy as a D-Genius group, I think advocacy is also a part of one of our vision and mission. Advocacy to use and sustain the existing initiatives that we are making currently. We have to come together, join together. Instead of just looking into a unifocal manner, we have to together work not just for the registries, but also for the advocacy that comes along. How do we bring value? We have to translate the data into some sort of paper, manuscript, publication, so that we can get critics also from the mentors that we have. We can get a good amount of visibility across the world that this group is doing something great. So that's the thoughts that I have. This was a WHO and the European reference network examples that we have for the registries, and this is one of our papers. Dr. Banshi Sabu sir and myself were a part of this type 1 diabetes registry in the developing countries, and this was a perspective from India. We did this in 2019 at the time, just pre-COVID, when we were almost designated as the hub for Southeast Asia, and we wanted to show the world that the developing countries are equally competent enough in terms of registering the data, coming out with evidence, translating the data into clinically relevant practices, and that's that. So with that, like Rutul was suggesting, there is an RSSDI type 1 diabetes insulin project wherein you can connect, and that's our institute. We are a part of a lot of registries ourselves, and sometimes you feel inadequate कि आपके पास इतना सारा data है, करोगे क्या उसका? So I guess that is why this is the group, and I'll give over the mic to Dr. Rutul to take up forward. Thank you for the patient listening.
Thank you for the wonderful talk, and definitely we should make some of the committees, like for type 1 registry. I would like give an example. Dhruv is too much interested in type 1 diabetes. Some of you may be interested in newsletter. So we'll make committee this time of 4 people, 4 or 5 from different regions, and we'll include everyone in this different groups. And please, it is request, because what happens when we make the group, everyone is excited. Yes, today everyone is excited, we want to do something, but when we went back to home, we are busy in clinical practice and our social responsibilities. Everything is vanished. So please, when we make the group, keep it active, because it is sometimes too much burden for a person to tell that please do it. Like for this case, hypoglycemia case series, I had to tell everyone that please send it. It was like 2.5 months it took for just one of the cases. Like it had only 300 words, not more than that, and the references. So it is not that difficult, but yes, be focused for our D-Genius group. Definitely you are going to be leader ultimately in some of the things. Like for newsletter committee, what I am thinking, this is my idea personally, that we'll change this committee every 6 months. So like for 6 months, some 3 or 4 people are in this committee, and they are circulating all the things. They are gathering the content for newsletter, and after 6 months we'll change this person. And some of groups will be permanent, like for type 1 or other things, like for complications if we are making, then those groups will be permanent. But yes, we can add someone else who are more interested in different kind of activities. So like I'm more interested always in hypoglycemia, and I'm seeing that it is one of the biggest problem, and it is one of the challenge to control our patient's blood glucose. So I'll definitely lead that hypoglycemia. For someone it is a type 1. For Dr. Amit, it may be like he is going to talk about a time in range for Rhizodeg today. So everyone has different thought, and we want to do each and every activity. But please make a group yourself. I can't choose a person for everyone. Like Dr. Amit wants to do this Rhizodec time in range study. So he has to select the people that, yes, you have to ask at least 5 to 7 people. We can add 2, 3 from my side or any other person who is more interested. But please be a little more active for that. And for next session, I'm inviting Dr. Amit Dey, who is from Kolkata, a very near and dear friend. So he'll be talking on a time in range for Rhizodec project that we are doing under D Genius Group.
So, good afternoon, everyone, friends, and all of you are very close to me. Yeah, I think. So, use the mic. Okay. So, as while we are getting ready, I've got one question for you, Dr. Dhruvi. So, this concept of Type 1 registry is it's very innovative. It's wonderful. How do you intend to keep it? Should it be an online registry? Should it be an offline registry? Your experience on that? Yeah.
You can connect it to the cloud wherever you the benchmarking. There's an nice data that is there you get the benchmark. Totally offline. Online the troubles are always and the piracy and privacy.
Absolutely. And also the data can be tampered and changed a bit. So that's the reason why I particularly asked you this question. So it's offline for us. Yeah. Yeah. Absolutely. Great. Looking forward to it. You ready? All right. All right. So what we were thinking about is just to be on time with the pace of things that's happening around us. We kind of brainstormed and thought of coming up with a real world study. And what I'm going to do is I'm going to take all of you through the study design, and we're going to spend a little time discussing the study design, because I think a lot of inputs can come in from all of you. We can even make small minor changes. If you have any additions, any deletions to make, feel free to comment and suggest. So this is what we're going to do. This is going to be a D-Genius project. What we intend to do is a multicentric observational prospective open label study, and we're going to try and assess the effectiveness and safety of IDECASP from CGM data. And the type of patients that we intend to include are insulin naive type 2 diabetes patients in our regular clinical practice. So we're going to try and keep this as simple as possible. So we're going to take in the insulin naive patients, type 2 diabetes patients. We're going to put them on a CGM after initiating them on Rhizodec or IDECASP, and we're going to assess the effectiveness of the molecule as well as look at some of the safety points. So this is going to be our primary efficacy endpoint of this study. So it's going to be to assess the change in the time in range from the CGM data. At 12 to 18 weeks, we can keep it at 12 to 24 weeks. So what we intend to do is to keep the study design about 6 months. So that's 24 weeks. Now what I have gathered personally, and we can take inputs from all of you, is to what should be the right time to do the CGM. What the Novo people tells me is that you initiate them on first 3 months, let them come up to a maintenance dose, and then you run the CGM to get the effectiveness in terms of the time in range. So that's one thing we can do. We can have an overambitious aim of doing 2 CGMs, so one at initiation and one at the end, but that actually may not be practical for all of us in our daily practice. So that's one consensus that we can come to. We can change this accordingly. So we're going to look at the insulin naive patients, patients who are either being initiated for the first time on insulin, or they're on a OAD on any other drugs and they're being changed over. In addition, they've been added a insulin. So that's going to be a criteria of patients. So these are going to be some of the secondary endpoints also in the study, and that's what we're going to look at. First is we're going to look at the demographics and the baseline characteristic of patients who are being prescribed IDECASP either as a monotherapy or in addition to OAD. Now, one thing I would like to point out here is just to keep the study very simple again. If any patient is started on an IDECASP and they go on to be added other insulin, So we wouldn't want to put them because then the efficacy part gets a little difficult to assess. So we're going to look at patients who are on monotherapy of IDECASP, or in addition to an OAD, an IDECASP has been added. That is going to be assessing the demographics and the baseline characteristics. The fun of it is we are all representing different parts of the country, so we can get a good data out of there. We're going to look at the change from baseline in the HbA1c after 12 weeks and 24 weeks. I think that's something that we all do in our practice. We do an A1c at 3 months and 6 months. We'll do it in the entire study population, and also we can create some subpopulation. Like I've created one. We can have a category of the elderly and the younger patients. So you can have like above 65 years of age and below 65 years of age. We can also, if suggestions come in, we can also create some other subpopulation category and look at the changes in the A1C. The third secondary efficacy endpoint would be to assess the percentage of patients reaching the glycemic target. That would be a TIR of 70%. That's our goal, is to see how many patients that we have initiated IDECASP as a monotherapy or in addition to an OAD achieves a TIR of 70%. That's the primary thought behind the study. And also we're going to look at whether the patient is achieving the individualized A1C target. And why we haven't kept a figure here, because again, you'll be having different subcategories of patient, their individualized A1C targets will be there. At 12 to 24 weeks of treatment in the overall study population as well as in the subpopulation. Then we can also get an understanding about their anthropometric changes. So we can look at their change in their weight, BMI, and the waist circumference. You can take one reading at the baseline at week 0, and then you can take another reading at week 24 at the end of 6 months. This is something that can come out of a real world study, is that we are going to assess the proportion of patients who discontinue their treatment due to unsatisfactory effectiveness or inconvenience or adverse events in the overall study population as well as in the subpopulation. We are also going to try and look at evaluate the mean difference in the dose of IDECASP when the physician decided to add, and at the end of 24 weeks in the entire population and as well as in the subpopulation. So you start your patient on some dose and then you up titrate, down titrate. So we're going to see the change in the dosing that has happened. And at every point of visit that the patient comes to the doctor, so it would be a week 4 visit, that's 1 month after initiating, then it will be a week 12 visit and a week 24 visit, if you take it that way. The patient can visit you more frequently, but those are the points where you record the data. At every point, you're going to record their fasting and PP glucose, and we're going to see the change, the mean change in their FPG and as well as the PP glucose. And when we are going to assess the safety of the molecule, these are the 2 parameters that we can look at. One is to first assess the number of reported hypoglycemic events. So that's when the patient reports to you that they've had an hypoglycemic event, so that gets documented. And also we look at the incidences of confirmed hypoglycemic events from the 14-day CGM that you're doing for your patient. So 2 hypoglycemic events, and the same we can do for nocturnal hypoglycemic events as well, because we're talking about a premixed insulin here. So these are the 2 safety endpoints that we can look at after collating the data, and those are the primary endpoints. So obviously, to keep it very simple, as I said in the beginning, we're going to include patients with only type 2 diabetes, insulin naive patients, and also to keep it less complicated, let's include patients who are having EGFR more than 45. Obviously, the exclusion criteria would be the other types of diabetes, type 1, gestational diabetes, etc., secondary diabetes, all those we won't include in the study to keep it very simple. So this is how you can participate in the study. First is you got to identify your insulin naive patients that you want to recruit in the study. You initiate them on IDECASP, and these are the 3 points at which you record their data. So at week 0, you record their fasting PP, HbA1c, creatinine, and also you look at their EGFR, weight, BMI, and waist circumference. So we take their anthropometric measurement on the first visit. Then at subsequent 4 weeks visit, you take their fasting and PP. At 12 weeks, you record their fasting, PP, and HbA1c. So thereafter, we'll decide on a window period that can be 12 to 18 weeks, it can be 12 to 24 weeks, or it can be 18 to 24 weeks. We can have a consensus on that, and we initiate that patient on a CGM somewhere between this 12 to 24 weeks. It won't be uniform for everybody because everybody won't be getting their patients to follow up at the same time. And then you capture the data. And again, at the end of 24 weeks, you call back the patient and you record all the vitals again. So you look at their blood profiles, you look at their anthropometric data, and you record them. So again, if you're interested to join the study, then we request you to register your interest, drop in your name with us. And then what we're going to do as a follow-up of this, we should always keep timeline for this kind of study, because after the meeting, obviously, we'll all be going back and then we'll all be connected on WhatsApp. So it's important we keep pushing each other on this. So we'll be setting up certain timelines. And what I intend to do is write up, once all of you are agreeing to participate in the study, let us know how many of you are there, who are there. And then we're going to send a data collection Microsoft Excel sheet to you. It's going to be very simple. And we're going to request you to record these anthropometric and laboratory parameters in the data sheet. What you're going to do once you put the patient on the CGM, you're going to analyze the CGM graph yourself in terms of the time in target which has been achieved, the overall hypoglycemic events, the nocturnal hypoglycemic events that you have recorded from the CGM or the reported events. And then you're going to record them in the respective columns, which will be very self-explanatory in the Microsoft Excel sheet that will be provided to you. And then you got to email your data back to us. We're going to put a timeline for that as well, expecting that all of you would be active in sending us your data in the data sheet that will be provided. And we also request you to send us your CGM graphs as well, so that we can have, we can also sit and work on it and get to understand that what is it we're looking at. So you can attach your CGM graph along with the data sheet. So what's next after that? What are we looking at in the next 1 year? This is what we're going to try and do. We had discussions with the Novo Nordisk team, and they've agreed to help us in analyzing the data and carry out the necessary statistical analysis. And of course, whatever result comes out of the study, positive, equivocal, negative, whatever comes out, will be communicated to each of the participants, each of the investigators via email before we go on for publishing it. And of course, we will target presenting this study as a poster in a popular international conference in 2023, because we are looking at a 6-month study from, say, June to December. You take another 3 months to, maybe analyze the data, get the posters ready, and then we can present somewhere in mid-2023. And the study will also be published in an in-text journal going thereafter. So this is the D-Genius project 2022-2023. So we look forward to your participation, and feel free to get back to us, register your interest. Yeah, so that's one point which we didn't put in. I intend to put that in. We will keep a portion in the Excel where we will mention whether the patient is on once daily or twice daily. That's where the titration part comes. So because you're talking about insulin naive patient, so most likely you'll be starting the patient on a once daily, and maybe majority of them would be on a once daily idacasp, but some of them may even get up titrated to twice daily. So that was my thought when I kept that titration part as what was the initial dose, what was the final dose, and is it once or is it twice daily?
That could be subgroup analysis, I would say.
No, exclusion criteria. So one exclusion is obviously the other types of diabetes we're not taking. People with EGFR below 45 we are not taking. And like I said, if the patient is on any other types of insulin other than idacasp in addition to it, so obviously we're not going to take, because the effectiveness gets altered. So we can't actually assess the effectiveness of idacasp. We're going to try and keep it very simple, so that the main aim is to get a CGM data.
There is no other paper on idacasp part
yes.
and time in range.
Yes, and we intend to collect the data from different parts of the country. So I think we can come up with some good data, and it would be something to work on.
The problem with this study, I would say, that I want 2 CGMs to be used initially when we start the study and at the end, but that you have to do on your own. That CGM part will not be covered from Diabetes India or from Novo, so that you have to, and even insulin as well. So this is completely the study we are doing on our own. So whoever is interested, Abbott? Harris, this is what you can do.
But it will be an individual investigator effort. That's what we want to put forward. And I think there's another reason why we want to keep it investigated, initiated CGM is also, to sort of rule out that ethical clearance later on, because again, if it becomes an intervention, we don't want to do any interventions. Like, we're going to kind of show that this is a part of the daily clinical practice of the clinician, that once you put a patient on a particular insulin, you are doing a CGM to assess.
So who is interested?
Yes, please, please. True, yes, we would.
That you will provide.
Yes. But then, yes, that's the problem. Now, that's one thing that we need to find a solution to. Is there any central clearance that we can,
that will
later
manage,
something we can work on?
Novo people will help.
Yes.
I would say Novo people will help.
Yes,
in
will help
ethics
us on
committee
that
approval.
also.
There is not a problem.
I
The
think
problem
let's-
is CG.
Yeah. See.
Retrospective.
So, Dr. Deepak, we intend to do a prospective study because it carries more value. So, and since we're doing a prospective study, we need to put it as a prospective study. Retrospective, it's people do retrospective study, but
No, that can be managed, but I'd say. So, yes, central committee, yes, central ethics committee. Yes. And what about Abbott? No, I'm asking about CG.
No, but Abbott will not help CGM. And I think definitely the study is very good. I think
Then we should use it.
They go with A1C, it will again become like the DCC data analysis, which then it is like semi-objective kind of thing. So we will have to go with this.
So we'll keep a window period. That's the intent. We keep a window period. So if you're doing 2 CGM, you can keep 1 CGM at 12 to 14 weeks. If you're doing the initiation, see, the problem which I feel, and that's what we were also discussing, is there's going to be a lot of variation. But then that's also something that you can pick up. You can pick that up. You can pick that.
Initially, you are going to
Initially, you can put the CGM, and then you can do somewhere between 18 to 24 weeks. Yeah. Yeah. This is the TR to start with, and this is the difference that you have got.
And your primary endpoint is seeing
To
the
see the
change,
effectiveness,
change
absolutely.
in TIR.
Yeah.
Yes.
Yeah.
Yeah.
Yes. So, yes. So we'll also keep that GLP part. We'll include in that exclusion criteria.
Okay.
Noted.
Oral
Yes.
is okay.
Yeah. If the patient.
No, but the patients who is already on GLP-1 oral, I would say there is.
So we'll. Yeah. So let's just keep the other OADs, and we just take out the GLP ones, and absolutely.
Okay. That's great. So,
So we can-
definitely the problem is CGM.
Yeah.
And I guess.
I think all of us use it. I mean, most of us are
we
using
want
it,
at
and
least, we want at least 100 patients. For that, everyone has to try a little hard.
we are looking at.
Go forward with a good number and a good number. I'm not saying go for a
As in our group, if we see.
It depends on how much each investigator is contributing. So that's.
Great.
Also, you
No, but this is a real world study. The point is that is the physician decision. The titration will be, so that's what you're looking at.
If we do it like an intervention, what we are going to do uniformly, it will be intervention.
It will become intervention. This is a real world study. So it's the physician who's doing the thing. So it will be based individualized in manner. Yeah, standard of care like that. Yeah.
Wonderful. Thank you, everyone.
Thank you. Do write back to us, any of us on WhatsApp group, so that we know that how many of you are there with us in this. Thank you.
I guess we are done. We don't need to have vote of thanks. Thank you, everyone. Thank you, everyone. Yes, bhai. Thank you. Great. Great.